with this next panel, which is entitled Testimonials for Inaction. We'll be able to provide, I hope, to you clear examples of where an integrated strategy has worked in areas of extreme importance. Our next panel provides testament to integration that was very influential in conducting recalls, in addressing imported food surveillance, and with a foodborne illness investigation. Our panelists will be Ernie Julian. Ernie serves as the chief of the Office of Food Protection for the Rhode Island Department of Health, and he has done that for the last 25 years. He serves on FDA's Preventive Control Work Group, developing the implementation plan for this new regulation. He served as the chair of the Council of Public Health Consultants for the National Sanitation Foundation International, and he also represents AFDO on the Council to Improve Foodborne Outbreak Response, C4. Steve Stitch. Steve is the current director of the Division of Food Safety and Inspection with New York State Agriculture and Markets. He is also the current president of AFDO and a member of FDA's FSMA operations team representing states relative to the imported food rules. Mark Reed is the current program manager with the Food Safety Branch of the Kentucky Department of Public Health, where he has worked for over 25 years. Prior to his state service, he worked with a local health agency where he standardized numerous inspectors in retail inspection practices. Mark is also a member of AFDO's board of directors, and I believe Ernie is going to go first. Ernie?
Thank you, Joe. Morning. So, integration, and we are asked to do testimonials here, so oops, went too far. There's actually an integration toolkit that was put together by AFDO, International Food Protection Training Institute. Jack Guzach was involved, and basically you can actually get a hold of that. It shows all the players. I'm not going to spend time on it, but basically it's everybody working together to provide safe food. So I'm just going to move on. So what do we try to do? So obviously we're trying to get federal, state, local agencies, industries, and others to seamlessly work together to detect, investigate, respond to, and prevent foodborne illness. And obviously with FSMA, prevention is the key. One of the things we talked about with the Preventive Control Work Group was reducing the time from, from detection of an outbreak or a hazard to implementation of effective controls. Thank you. Industry obviously plays a critical role with this. Thanks. One of the areas where it didn't work that well was PCA, with the peanuts. If you look here, you see from September through January, basically the outbreak went on before it was detected. A lot of cases. And in this outbreak, you had 9 deaths. You had about 700 ill. January 10th, the outbreak, you had a recall. You finally figured out what the product was, and it was a recall of peanuts. But look at all the illnesses that occurred after that. And what we're trying to do is obviously push that curve back, detect the outbreak quicker, put in place controls faster. We don't have all these people getting sick after the recalls go into effect. And with PCA, basically recalls went on for a year. I mean, that's not effective, obviously. People are getting sick. You've got all these deaths. You've got all these illnesses. You've got this huge economic impact on an entire industry, shutting down all these peanut providers of products. And so what we're trying to do is how can we reduce illnesses, reduce deaths, reduce the long-term impact on the industry, reduce disabilities. With C4, I chaired the industry work group for a few years, and one of the things we looked at is why recalls weren't effective. And we've seen in a lot of recalls that they weren't working that well. And why was that occurring? Well, obviously, the first thing is, well, the manufacturer didn't tell people, or the distributor didn't tell people. But sometimes the establishment received it and then didn't do the right thing. They didn't pull it off sale. Sometimes there was just mistakes, though. Sometimes the recall, as we see, expands, and the establishment was getting the expansion notice, but they took it as the first notice and they ignored it. They didn't realize that it expanded to other lots. Sometimes what was happening is you've got these teenagers working at customer service. So what happens? The person brings the product back to the store. They're looking for credit. And what does this kid do with it? They put it back on the shelf. So sometimes that was happening as a common source of error. The other thing that was happening is that sometimes a new shipment comes in. Well, they figure the new shipment's coming in, it's got to be safe. And it's a recall product that was still in the distribution system that hadn't been pulled off, but because it was a new shipment, they put it on the shelves. Sometimes we were finding that product was in multiple places in the same store. They pulled it off one location, but they didn't pull it off all locations. They forgot it was in multiple places. Sometimes you find that the product was removed from sale. It goes back to the manufacturer, but it was being diverted and showing up in other places and being sold. We've got a recall grant from FDA. One of the things we're looking at is the root causes. So if people are getting sick after the recall, why is that happening? Is it a notification issue? Is it the consumer didn't see it? What is the purpose for that? And what can we do to make recalls more effective? One of the things that some of the better companies have done is they're looking at direct customer notification. Instead of just putting out a press release where every day I start off the day looking at what's being recalled today, and it's like crying wolf, and people ignore those, they're looking at, all right, text messages. You know, you bought this product yesterday. Don't use it. Now all of a sudden it's something tailored to me as a buyer. Based on shopper card, loyalty cards, you know who bought certain products. They're using emails. They're using blast phone calls to call people. They're using other direct notification techniques to improve recall effectiveness. One of the examples that I was involved with that probably involved the most players as far as integration is the Salmonella Montevideo outbreak that went on in 2010. There were 272 cases. There were illnesses all over the country. The outbreak was going on for 6 months. Bill Keene, who was a great epidemiologist in Oregon, notified me. He sent me an email on January 15, 2010. I can still remember it. He said something may be going on from salami produced in Rhode Island. And I said, uh-oh. You know, basically, this had been going on for months. They had 6 people who had all bought salami from Costco. They got permission to get their shopper cards, the loyalty cards. They found they had all bought this salami from the same company. We went into the facility. And again, what we're trying to do is prevent rolling recalls. We're trying to prevent illnesses. We're trying to prevent more deaths. We're trying to prevent the economic impact from dragging on. And in talking to the owner, USDA would have said, well, hey, we know that we've got the positive salmonella when we finally did some testing in one lot. And we would have recalled 78,000 pounds of product in that one lot. And looking at it and looking at the root cause, we said, we really thought it was pepper that was used in the product that caused the problem. And we recalled 1.2 million pounds. I mean, the owner agreed to do that to avoid rolling recalls. And he was very responsive, and he did the right thing, and it turns out that was really the source. As we did more testing and we went on, we found, and that was 3 months of my life in this investigation, working with FDA, USDA, CDC, and other states and the industry, we found salmonella in pepper, in black pepper, and in red pepper. Excuse me. Excuse me. So when we looked at the pepper, we found salmonella in pepper from 3 different countries: Vietnam, China, and India. And basically, the owner's mistake, if you can call that a mistake, and I guess it was, is he was relying on his suppliers. The product was reportedly treated. It was reportedly tested. It was supposed to be salmonella-free, and we were finding about 2% of the product was positive for salmonella. So, and that almost put them out of business. So, and now they're doing very well, and they put in additional treatment, and they're doing their own testing to verify the supplies of all the products coming in that are using ready-to-eat products. But, that was a major error in that area. FDA, as a result of that, increased testing of pepper coming in the country. They looked at efficacy of treatment. FDA did a risk assessment. They found 12% of the spices coming in the country were contaminated with something, rodent droppings, insects, whatever, and 7% were contaminated with salmonella. So again, a lot of players, multiple states, industry, FDA, USDA, CDC, all working together and finding that basically spices coming in were a problem. And if you're using spices on ready-to-eat products, that's a hazard. And some companies were using spices after cooking. Well, okay, you killed the organisms, now you're seeding it instead of using it before cooking. So some lessons learned there. One of the things that Bill Keene also sent me about a year and a half later was a New York Times article, and it talked about salmonella in spices prompts changes in farming, and it showed in India that they were changing their farming practices as a result of this investigation. And I think that's the key here is integration is industry, states, locals, feds, all working together, finding the root cause and eliminating the root cause. Another example is I was teaching an outbreak investigation course in Washington State, and at lunch I received a notification of an outbreak in Rhode Island. The people ate hamburgers, they eat turkey burgers. I said, it looked like salmonella. I said, well, it's probably going to end up tomatoes that time of year. A week later, the state epidemiologist calls me and said, we've got a matching case, PFG genetic fingerprinting matching case to you in Rhode Island, 3,000 miles apart. There's 42 cases in the whole country, and we've got matching cases. And they were blaming sliced turkey because people ate in 8 different stores and all had sliced turkey sandwiches. And it turned out that we found tomatoes were the source. But what was most interesting is right after that, I flew to Canada. I was giving a talk on slicers being a problem, that they were uncleanable. And I was showing the picture basically of this. That's a slicer cover. It goes on top of the blade. And I was showing that picture, and I flew back early on Friday, and I was meeting with the owner of this place that we had shut down, this restaurant, 7:30 on a Friday night. And what do I look at in the table in his kitchen was that. And I said, I just showed a picture of that slicer causing an outbreak in Georgia in 2006. And that... So Monday, we took these pictures. These were actually in Rhode Island. We took off that white piece of plastic, and we found the outbreak strain underneath there. So the root cause was, it wasn't just this restaurant that caused the outbreak. Looking at the root cause, we found that tomatoes that came in from Florida caused 42 people ill throughout the country, and that these slicers were uncleanable. That basically the silicone seals around these plastic breaks down. Food gets up into there, salmonella can get up into there, listeria can get up into there, and that can be a source of illness. So we worked with NSF International, and basically slicer standards were changed nationally in 2012. So the new slicers coming out are better designed to avoid that. But the old slicers out there, and there's probably 100,000 of them out there, if that silicone seal breaks down, they can be a source of salmonella and they can be a source of listeria. So again, looking at the root cause. We worked with FDA. FDA put out 100,000 posters for the industry and for health departments to basically inform them of this. Integration. So one of the things I tell my staff is, as we're doing outbreak investigations, we're looking for things that may be a problem in that establishment that may be causing illness elsewhere. It's not just the establishment caused the problem, but how did the bug get there? Is there an unsafe ingredient that may be elsewhere? Is there unsafe equipment, such as the slicer, that may be elsewhere? Are there corporate policies or practices that are basically throughout a whole chain or a corporation that may make them unsafe? Think of PCA, the Peanut Corporation of America, where it was salmonella's in a product, just ship it, and he's got an operation in another state. Is there a lack of knowledge? I was in another country evaluating their program, and one of the things that they had training and certification, and I'm talking to this person, he's improperly cooling food, improperly reheating it, improperly storing it. I'm asking him questions, didn't have a clue, he was trained and certified. I said, somebody's selling your test. And we had that happen in Rhode Island, where we found that people had gone through our certification program, couldn't answer basic questions. We found somebody was taking the test for them, and we decertified 500 people, and we notified the person, the company that he was doing the test for, and he was pulled off, and he actually skipped the country. So, but again, we're looking at root cause. Is there motivation is an issue? If recalls are ineffective, with PCA, Massachusetts found that Austin crackers were being found and sold in gas stations. Well, them telling us that, we went into those gas stations and pulled it off there. And then you look at, well, why is that happening? Is it the gas stations in this chain that aren't pulling them off, or were they not told by the distributor? If they weren't told by the distributor, then we need to contact the distributor and get on their case to make sure that this product is being pulled from sale. So basically with integration, again, communications, federal, state, and local level, working with the industry, looking at the root causes, looking at, all right, is there something national or regional in scope that should be addressed across the board? We're going to hold questions, I think, because there's multiple speakers. But that's basically what I wanted to share with you on the recall part. Thank you.
Thanks, Ernie, and good morning. I think that I do have a clicker here. I think that most state food program managers would tell you that they tend to specialize in certain areas according to the industry that's handed to them. So, for instance, Alaska is known for its salmon, and Providence maybe for its shellfish, and Kentucky for bourbon. But a lot of food is imported into New York State, and because of our cultural diversity, a lot of it stays there. And so while we're participating in a lot of the recent and current initiatives that the last panel talked about, I want to talk about our imported foods initiative in New York. And it kind of began with some of these partnership agreements that New York has had with FDA, starting in 1999 with our food recall activities. And this isn't just responding to national recalls, but really addressing the recalls that we initiate ourselves in New York by our inspectors' observations, by results of sampling, surveillance sampling that they've conducted, and how we respond to that, audit checks, all of those things. And so then in the year 2000, we had two other partnership agreements. One, the operational planning and communication, where we're hopefully talking to each other, FDA in New York, so that we're not tripping over each other, this day or the next day in a food facility, and that we're communicating on our activities, even insofar as compliance. Information sharing, that means inspection results, recall data, sampling results. And then in 2002, we kind of rolled those three partnerships together that I just talked about, and we added in another one on emergency response plan, kind of like a precursor to the rapid response teams that Travis talked about. So through all this work with our food recalls, it quickly became apparent that about 70% of all the recalls that our inspectors initiated, about 300 a year, were due to imported foods. And so in 2004, we started our Imported Foods Initiative, which really isn't a formal partnership, but really more of a grassroots agreement between the resident post that started in Buffalo and New York State Ag and Markets. And so the key elements to this initiative were information sharing, again, sharing information on sample surveillance and so forth, sharing inspection results and product examinations, but not just sharing information, but working together on joint inspections. We had started with 6 inspectors that specialized in imported foods. They were still doing their regular day job, but maybe 1 or 2 days every 2 weeks they would specialize in imported foods, and they would embed with FDA officers and U.S. Customs and Border Protection at the borders, and we learned how FDA and U.S. Customs works at these borders. We worked on food and feed sampling at the borders. We participated in recovery efforts. That is where food is imported and FDA might take a sample and that food might go to a different location, and the sample result might indicate that the product has to be recovered. And so we've assisted in some of those activities too. Utilizing resources, again, that means that we're using some of our best inspection tools. If it's better that FDA respond to this and we respond to that, then that's what we do. And also, our resources means compliance tools and enforcement tools. Which one has the better tool for this situation? So these were some of the results of this. Yes, we did practice what we preached. We did share information. But we also were able to contact FDA when we ran across a low-acid canned food or an acidified food, and we could call our local contact at a resident post and have them look up whether or not this particular container of food was registered with FDA. And many times we found that they weren't. We uncovered several unregistered facilities in New York that we were not aware of. Some of them were pick and pack warehouses where imported food might sit, but domestic foods may also reside there. So also some laboratory protocols were developed, and this started our integration of our laboratory so that we could better share laboratory results. We also developed some new protocols in testing, such as testing for mammalian proteins related to BSE and animal feed. And those laboratory protocols also led to the last bullet here, which is an FDA compliance tool called an import alert. And what that means is that FDA can detain a product upon entry. based on information. And we provided information to FDA. We have shared since 2000 all of our recall information with FDA. But in particular here on imported foods, we could provide them with sample results and import documentation, provide that information to them, and based on the state's evidence, they could go forward with an import alert. This was something that had never happened before, and I think we had our first one in 2004 or 5. And we're on this slide we'll show at the bottom, we're more closer to 50 probably. We have a little trouble tracking, import alerts and who's provided the information to develop that. So these 6 inspectors, this is the work of those 6 inspectors that I mentioned, over 2,000 assignments. What that means is this really is establishment visits. Over 6,000 physical exams. That means every product that they looked at. And we really didn't even start tracking that until about 2007. So I know that number's higher than that. 373 food seizures of adulterated food, over 1 million pounds. 1,200 food samples, 314 of them violative. What that tells me is that a quarter of the samples that these 6 inspectors took were in violation. I think that's pretty effective sampling, and that's pretty good eyes, knowing what they're looking for, knowing what they're looking at, and also getting confirmation from the food lab. About 400 recalls. This says 397. It's almost May. I'm going to say we're definitely over 400 recalls right now since 2004, and 40 of them were Class 1, or about 10%. So I should have blown this slide up a little bit, maybe condensed it a little more. It's going to be hard to read. But the top columns show the years and then the different classifications of recalls. Class 1s, those are one of the ones that we all hear about that have a press release. These are the most pressing recalls. They can result in serious death or serious illness or death. That's a pretty serious illness. And then we have Class 2s and Class 3s. But really, in the bottom right is the total. And so over 4,000 recalls in the last 14 years, or about 300. And again, these are initiated by our field inspectors. And these, it kind of started with those 6 inspectors, but through sharing information with our other inspectors, we now have a whole pool of inspectors across the state that are aware of some of these food products and some of the concerns with them. And still about 70% of our recalls start with imported foods. Okay, so there are a lot of stories behind some of these products. They're all interesting. Some of the most interesting ones are the imported foods, or the ethnic foods. But I won't get into that. Really, finally, what I'd like to say here is that I had a question one time when I finished one of these presentations, and the person really made more of an observation and said, "Well, gee, these are mostly ethnic foods," and I think what she meant by that was, well, there's not a lot of volume here. Well, I can tell you in New York that there is a large volume of imported foods. Number one, but number two, I tend to talk about some of the more interesting stories, and those more interesting stories are some of those ethnic foods. But if you see in the bottom right-hand corner of this slide, there is a bulk tote of peanuts. This is one tote. One of our investigations revealed over 50 tons of adulterated peanuts that were imported from South America. So I don't think peanuts are something that we consider to be an ethnic food. So we think this is important. FDA also agrees in our New York district, and so we work very closely on this, and we have for many years. So thank you.
Hi, well, good morning. My name is Mark Reed. I am with the Kentucky Department for Public Health. It's a pleasure to be here. What I want to share with you today is a recent experience that we had in Kentucky in a foodborne outbreak investigation that I think clearly demonstrates and shows you what I think integration really is. Before I start, what I think you'll see in this is integration is more than just the state health officials or the state health department, state food safety communicating with FDA. And the one thing I think you'll see is that there's a number of disciplines at the local level, at the state level, and at the federal level. That's what I hope that this will demonstrate to you, that truly there is collaboration and communication at all three tiers of government. It also includes our industry stakeholders, which is many of you, as well as even academia. So let's set up the big picture. In 2012, there was a multi-jurisdictional outbreak involving several states related to Salmonella typhimurium. And remember this 0324 strain. So the big picture, there were about 239 illnesses across 24 states. 70 of those cases were actually from Kentucky, and we had the largest number of cases. It was a particularly virulent strain, about 75% hospitalization rate, and there were 3 deaths nationally as a result of this outbreak. So I'm not going to go over this slide, but the first thing I want you to understand is my branch, the food safety branch in Kentucky, did not see this outbreak as it was occurring. And here's one example of integration inside our state. Our Division of Laboratory Services and our Division of Epidemiology, our disease detectives, actually saw the signal first, the red flag, if you will. And you can look as we go across this graph, which actually demonstrates July, August, and September of 2012. Do you see a signal there? The blue kind of shows you 2008 to 2012, 4 years combined of what we normally would expect to see regarding salmonella cases in Kentucky. And you can see in the summer, those cases do go up for one reason or another. But if you look at the other part of that graph, you can clearly see the signal. Something is going on. When we looked at those salmonella cases, what we found was that many of those, in fact, most of those, matched the Salmonella typhimurium 0324 strain. Again, another red flag. Here's a timeline of the events. I won't go into all of this in detail, but what I really want to emphasize on this is the number of state partners that you see that responded to this outbreak, the federal partners that were involved, and also our sister state agencies. And again, it all started when our Division of Laboratory Services in Kentucky and our Kentucky Division of Epidemiology saw this red flag event, and we started scratching our heads and saying something is wrong. That's where it started, but as we moved on down through the timeline, from July, August, and September, you'll see that we had local health department involvement, nurses, public health, local health department food safety inspectors. We had those same disciplines, epi, lab, food safety at the state level, and also later on at the federal level. We were communicated closely and collaborated with CDC and FDA, as well as those same disciplines in our sister state of Indiana. And what we eventually found out, I keep referencing Indiana, but eventually we determined that the source of this outbreak was from a produce farm in southern Indiana, and the actual vehicle was cantaloupe. I don't know if anybody remember this outbreak from 2012 in the summer. So again, as we worked the outbreak and did our investigations, again, it involved multi-jurisdictional communication and collaboration. And again, it involved the disciplines. Again, you heard this earlier in Travis's speech. Local health department officials, food safety inspectors, public health nurses, local health department and regional epidemiologists. Involved those same disciplines at the state level in my office, as well as at the federal level as well. We had a number of conference calls. They were all inclusive with a number of the states that were involved in the outbreak. We also included our local health department partners, as well as federal and other state agencies as well. So in our epidemiologic investigation, as we started looking early on, as our epi folks did the hypothesis generating questionnaire, we saw a linkage there between perhaps melon consumption and illness. And we looked a little closer and decided at that point we probably needed to develop a melon-specific questionnaire, which we did, and with the assistance of our local health department partners and our regional epidemiologists, then we administered that questionnaire to those who were ill and drilled down a little deeper. And so we looked at, in this investigation, as we focused more, as the red flags continued to lead us towards melons as a possible vehicle in this outbreak, we then determined that we needed to look where the product was purchased, when it was purchased, and when it was consumed. So again, we coordinated at my department once we came on board, and once we were made aware that there was a possible outbreak going on, then that's when we jumped in and began doing some traceback investigation, going from the fork all the way to the farm. And it started, first of all, with the ill individuals and drilling back down to where did you shop, where were the melons purchased, and then once we got there, then with the assistance of our local health department personnel and stakeholders in Kentucky, we actually went to the supermarkets where these melons were purchased, and then also determined then where the distributor that distributed this product to the supermarkets. In all, we collected, with the assistance of our local health department partners, again, I can't emphasize our reliance during this outbreak on our local health department partners. In Kentucky, we have a local health department in every county. They truly are our boots on the ground. We might have served as the conductor for this outbreak, but they actually did the boots on the ground, the shoe leather work for us, for which we are eternally thankful. We collected about 39 melons, I think. Some included watermelons, but 22 of those were cantaloupes. And here's what we found. Again, this is what our lab found, one of our partners in this thing we call integration. 2 of the 22 cantaloupes did test positive for Salmonella typhimurium. As we went on a little closer and looked a little closer after a couple of days elapsed, we determined through PFGE that, oh my gosh, these melons actually contained the outbreak strain of Salmonella that had caused the clinical illnesses. So another red flag, wouldn't you say? So we continued our traceback, and initially we weren't clear whether these melons may have came from a single distributor. Maybe there was cross-contamination, commingling of melons from different farms or whatever, or we weren't sure whether they might have came from a common farm. So we drilled down a little deeper. We put on our CSI hats and continued to investigate with the help of CDC and our local health department partners and our partners at the local, state, and federal level in epidemiology. So as we continued, this is a very simple schematic of what our traceback actually looked like. But for each individual that we were able to communicate with and talk to, we determined where they did their shopping, what supermarket chain they went to. We started to see a trend there. There were 2 particular supermarket chains that were scattered throughout multiple counties in Kentucky that seemed to keep showing up in this questionnaire. So again, we decided we would drill a little deeper. As we went, and with the assistance of our local health departments, to those supermarket chains and asked them where they got their product, we saw a really interesting pattern is most of them got their product from a single distributor. That's when then, with the intelligence that our local health departments provided us, my branch, the food safety branch, got involved and actually went to the distributor, which is one of the companies that we regulate, and determined from that distributor that most, if not all, of these melons came from a single farm in southern Indiana. So long about this time, guess who we were on the phone with and guess who we were emailing with? Our partners in Indiana, epidemiology, public health, and food safety. So following our notification to our Indiana State Department of Health officials, they actually made a visit to the farm along with FDA's CORE, Coordinated Outbreak and Response Evaluation Network, actually took a number of samples, environmental samples, soil samples, and food samples. This is what they found. In all of the environmental samples that were collected in the packing shed, including water samples and cantaloupes from the field, we found a number of pathogens, some Salmonella, different strains of Salmonella, even some E. coli, but we didn't find on the farm, we did not find the outbreak strain in the suspect product or the vehicle, which was the cantaloupe. However, we continued to take more samples, and again, this is Indiana and FDA at this point. In the soil samples, we did find an exact PFGE match of Salmonella, the 0324 strain, which matched the clinical cases. Pretty much we had connected by this point all of the dots. And at this time, the farm in southern Indiana was well aware that we had strong epi links to his product and distribution, and then the soil samples kind of sealed the deal, so to speak. But the farmer himself, which I would relate to being industry, was also very cooperative and voluntarily, not only did he seek to voluntarily recall the product that was still out in commerce, but he also ceased the harvesting of the rest of his product. And he had lots more acres of cantaloupe that were still in the field ready to be harvested. But by this point, he had voluntarily basically ceased the cantaloupe production process. So, in summary, this is what, as a public health official, this is kind of what gives me the warm fuzzy when I go to bed at night. Truly, through integration with our assistance at the state level, from our epidemiology partners and our lab partners, and with the assistance of our local health department partners who went out and actually collected the cantaloupe samples and also assisted us in the earliest stages of our traceback investigation, we were able to basically identify a food vehicle that was causing not only this outbreak in Kentucky, but multiple states again. We were able to quickly mobilize, see that the product was removed from the market, again, voluntarily on the part of industry, and this quick identification of this outbreak ultimately, I'm sure, certainly reduced the number of people that got sick, reduced the number of hospitalizations, and ultimately lives were saved, and all because of this model for integration. And this was one thing that no single agency could have done on its own or accomplished on its own. We truly, through integration, we each depended upon one another, and we were each interdependent of one another, again, at the federal, state, local level, all three of those disciplines. Afterwards, Kentucky and Indiana, because of our joint investigation and traceback work, were nominated and received a very prestigious award, which was quite an honor, the John Gazayich Environmental Team Award. And we were recognized during this outbreak as a model for intrastate, I want to emphasize that, in Kentucky. We practice integration at the state level. In my office in Kentucky, we practiced integration also at the local and state level. So intrastate and interstate collaboration. Scott Gilliam, who was the program manager in Indiana at the time, the food program manager, certainly credited Kentucky partners and basically acknowledged that we laid the groundwork for their additional successful investigation in Indiana on the farm. And again, this is kind of what integration looked like in this particular instance in Kentucky. Again, you'll see federal, state, and local officials. You'll see several state-to-state communication and collaboration, and you will also see local, state, and federal government collaboration among many disciplines, again, food safety, environmental health, epidemiology, and public health. And at that, I will end the presentation. But I think again, a great model for integration, and we didn't just practice that in 2012. We try to practice it every day. So thank you all.
Well, we got lots of time for questions now. Are there questions? We have plenty of time. Sir, can you come up to the microphone, please? Thank you.
This is for Mark. I'm Wayne Labs with Food Engineering. Do you remember if that might have been the same year as the Jensen Farms Colorado Salmonella outbreak? Yes. Or was it plus or minus a year?
If I remember correctly, the Jensen Farms, I think, was in 2011. Is that right? And ours was 2012.
Anyone else? You know, Ernie mentioned, and I wanted to jump on it a little bit, that the IFPTI, the International Food Protection Training Institute, has put together some programs on integration. There is a a web-based program that I believe is available to everyone. There's an opportunity for a face-to-face meeting, and there is an actual toolkit that can be used within jurisdiction to bring stakeholders together to sit down and to conduct an assessment of how well they are integrated. A lot of jurisdictions might think that they're really well integrated, but when they sit down and go through this really comprehensive assessment, they may find out that they're not. And it offers them an opportunity to put an action plan together so that they can improve on their integration. And as it has been pointed out, it's not just integration with everybody. The states need to integrate with their locals. The federal agencies need to integrate amongst themselves. The state agencies must integrate amongst themselves as well. So my thanks to this panel, and we'll excuse you. Again, don't be afraid to submit cards for them. And while they're leaving, I'll ask our next panel to come up, please.